And we've finally made it to birth. This is Katrina Anderson, and today we get to talk about labor and birth, also known as parturition. I'm really excited that I get to have this lecture with you guys because I won't be teaching pregnancy care or birth care moving forward, but I feel a little bit excited that I get to give you your first taste of it. So let's talk about the physiology. But just to put it in a good context, I apologize if I've already given you this quote. This one's probably one of my favorites. But birth is not only about making babies, birth is about making mothers. Strong, competent, capable mothers who trust themselves and know their inner strength. And I think that is one of the most beautiful pieces that we give women by allowing them to be themselves in labor and allowing them to fully experience just how strong they are in labor. I think this first hit home for me with this one mom who really was a total rock star in labor. First baby, the image that came to mind for me with her labor was that she was like a lion. Probably the last 3 hours of her labor, she just roared through every contraction, and it wasn't in like a I'm out of control kind of a roar. It was just like I am feeling so much, and there was so much strength pouring through my body that some of it just has to come out of my mouth. It was, I guess, how I processed it. And I remember about 2 weeks after the birth, she was having quite a bit of trouble with breastfeeding. And she was a doula herself, and she'd been working primarily with a lactation consultant quite a bit. But I was just checking in with her, and she said, you know what, I think if I hadn't had the birth that I had, this would be too much. But birth is what showed me that I really am capable of doing anything. And yes, this breastfeeding stuff has been tough, but I absolutely know that I am capable of getting through this. Because birth showed me that I am capable of getting through anything and of being just an incredible mother. And I will always have that to hold on to as I encounter all sorts of challenges as a parent. Like, I know that breastfeeding's just the first one, but I have the birth to look back on to remind me just how strong I am. So this work that we do, how does it happen? Let's start talking about the physiology of birth. So briefly, we're going to talk about different theories for how labor is initiated, and then we're going to go through a variety of different body systems for talking about how her body changes. Each system is changing during labor, and then we'll talk about third stage, followed by facilitating maternal and infant attachment. So, brief overview, the 4 P's of labor. So how are we going to get the baby out? We need power. That's basically a uterus that's pushing the baby out, as well as mom's maternal effort in pushing the baby out. We have a passenger who we've already talked about, thinking back to when we talked about the pelvis and how baby's able to navigate his or her head to get through the pelvis appropriately. And then we can talk about the pelvis itself for the passage, which we've already basically addressed, so we won't get into that too much here. And then psyche is always playing a big role in this as well. How safe does she feel? Is this a place where she can just focus on laboring? That could be a whole lecture easily on its own, but just that mind-body connection that can influence labor. So how does labor start? Lots of different theories on this, so we're just going to kind of chat through some of the dynamics that are going on. So it involves the fetus, so the fetal hypothalamus and adrenal glands are sending off stress hormones that are prepping baby to be ultimately ready, but that's also signaling to mom's brain, hey, I'm ready to go here. And then we have membranes, the mom's membranes as well as the placenta that are also giving off hormones, the prostaglandins especially with the membranes, but the placenta, we'll see placental hormones coming up here for influencing mom getting ready. mom's hypothalamus, and then we really don't totally understand it, but these next few slides are going to flesh it out a little bit. So, uterine activity during pregnancy. We've talked through this first bullet point quite a bit already. So, with phase 1 here is the quiescence phase, right? So that's where progesterone is most dominant in keeping the uterus quiet. We're not wanting to have a baby. So even if oxytocin was being released, the progesterone is keeping the uterus as a quiet environment. So the contractility isn't very responsive. You also have relaxin and prostacyclins here that are helping to facilitate this as well. But progesterone's our big player there. And then activation, we're starting to get close to being receptive for labor. So we might start having some Braxton Hicks. Our body's kind of getting prepped for labor. So our progesterone is starting to dip. Mom might notice that she has a little bit of maybe loose stool or diarrhea that's cueing us that her progesterone is slowing down. Estrogen is causing more gap junctions to start forming on the uterus so that the uterus can contract as one unit, like the heart can contract all together. So estrogen is prepping the uterus that way. Prostaglandins start to be released and start softening up the cervix. So all of these are happening. Baby's releasing cortisol, which is letting mom know, hey, I've got this stress hormone happening, I'm getting my lungs developed and ready to go, I can do this. So all of that's happening. And then in labor, no surprise here, we've got oxytocin, that's our ultimate uterine contraction hormone, right? And then prostaglandins are also causing contractions and then playing a big role in cervical ripening as well. And then we have our baby, and we need the uterus to get back down to size to slow down bleeding. So oxytocin is continued to be released here so that our uterus can involute or come back down to a normal size. And there's quite a bit of inflammatory cell activation changes as well during that time period. All right. So labor initiation, this is just kind of another way to look at it. So we have our fetal hormone players here, so fetal adrenal glands, we've got androgens, mainly DHEAS, and then cortisol, that's leading to lung maturity, and also helps to prompt increased placental hormones. So estrogen namely here, because we have our progesterone that's starting to dip, right? So as progesterone dips, our uterus becomes more sensitive to stretching and sensitive to oxytocin. Estrogen helps to release more prostaglandins, which are also helping, estrogen's also helping with those gap junctions, like I already said. Prostaglandins, their big role is going to be in softening up the cervix and getting the cervix and the vagina ready for the birth. And the more pressure that's on the cervix and the riper the cervix gets, that also prompts our posterior pituitary gland to start releasing oxytocin. So starting to have in our mind, where are all these hormones coming from? Our estrogens coming from our placenta, oxytocin's being released by the posterior pituitary gland, etc. So uterine stretch plays a role as well. The more the uterus stretches, the more gap junctions are formed, and also the more increased oxytocin receptors form. So the bigger the uterus gets, I like to tell moms it's like there's more baseball mitts that are forming on the uterus that can catch the oxytocin. So unless those mitts are there, then you can dump all the oxytocin on it you want, and it's not going to cause your uterus to contract. But as your uterus grows and stretches, more and more oxytocin receptors form on the surface of the uterus. So you can see here that this is a mom who's carrying triplets, and that would be one of the reasons why multi-gestation mamas or mamas with polyhydramnios, where the uterus is extra distended, they're at a higher risk for preterm labor because they're forming more oxytocin receptors and they're forming gap junctions sooner than they would if there wasn't more than one baby inside. Okay. So we already talked about how progesterone is inhibited at term, so I'll just go through this briefly. But so it's a functional withdrawal. we don't really understand why it goes down. Levels are still higher, but they don't tend to have the same function at the uterine level. So different body systems become less responsive, essentially, to progesterone. So its effects are withdrawing, but it's not necessarily the level itself that's withdrawing. So there's increased inflammation as a result, decreased ability to inhibit contractions. And then there's a couple different ways where we can see how this is the effect in the body. So that first one there, the RU486, blocks progesterone, which can lead to an abortion or uterine emptying. So we know that progesterone is helping keep the uterus quiet. So if the progesterone is blocked, then the uterus is more likely to contract and empty the uterus. And then there's supplements that can be given that are progesterone that can decrease preterm labor. So we see that as well. Okay. So prostaglandins, they're used for cervical ripening. You can give it pharmacologically, so that would be topical typically, or you could take it by mouth too. That would be like Cytotec or Cervidil would be examples there. Semen also has prostaglandins in it, so similar way to go about it. And then they both are causing inflammatory responses within the uterus. So they lead to cervical ripening in softening up the cervix, but then they can also cause contractions as well. And they can be part of what's causing diarrhea in early labor, on top of the decreasing progesterone. Not everyone has diarrhea in early labor. I don't want to imply that. Okay. So many precursors, different ways to officially get there for labor initiation. So cervical change, we know, occurs throughout pregnancy. It gets softer and softer throughout pregnancy, but it really accelerates that last trimester. So PGE2, that would be prostaglandins, and that's the same as Cytotec there. And then relaxin, estrogen, all of those play a role in helping with cervical change. Placental hormones stimulate oxytocin and vasopressin receptors in the myometrium and decidua, which we already mentioned as well. So that's our summary for labor initiation. Along with, so we know that oxytocin is released in pulses throughout pregnancy, but with progesterone it's quiet, so it's not as effective. But that causes strong contractions at term due to the increased number of receptors. So oxytocin is being released all of pregnancy. Uterine distension at term increases the oxytocin receptors in gap junctions, like we've said, and then transient hypoxia and contractions at term stimulate fetal stress hormones, oxytocin, vasopressin, as well as ACTH. So the uterus is more receptive, labor starts, and feedback with the hypothalamus causes the increased oxytocin in a nutshell. And then let's just flesh out oxytocin just a little bit more. We're used to thinking about negative feedback loops in the body, so if something is high, it triggers something else to be lower to decrease the high piece. I don't know if that just made sense, but usually we talk about negative feedback loops. But with labor, it's a positive feedback loop. So basically, the more contractions there are, the more oxytocin is released. So let's just look at this chart really quick. So we have estrogen from the ovaries that ultimately is inducing oxytocin receptors on the uterus. And then we've got oxytocin that's stimulating contractions, as well as stimulating the placenta to make prostaglandins. Prostaglandins are also stimulating the uterus, and then as the uterus is being stimulated, that's causing a positive feedback loop up to the posterior pituitary again to end up releasing the oxytocin. So uterine contractions, pressure of the fetal head, prostaglandins, and then also thinking about pressure from the inside that goes all the way around, so the membranes are pressing up against the full uterus as well as the cervix, causing equal pressure everywhere there. That's also like stimulation as well. Or thinking about cervical stimulation as well, whether it's your fingers kind of doing cervical massage, or whether it's baby's head, or whether, say, you're putting a Foley bulb in her cervix in order to see if that'll help to dilate her cervix, that's also causing pressure, which is sending a message up to the brain and feeding into that positive feedback loop to increase oxytocin release, also known as the Ferguson reflex. So prostaglandin release is stimulated, oxytocin pulses increase. I've basically just said all this, so I will let you read it. I feel like I'm telling you the same thing over and over, so I apologize if it's getting rough. Okay, we're going to touch on each of these now as we think about maternal adaptations to labor. So with the cervix, its function all of pregnancy has been to protect the fetus by remaining tightly closed during pregnancy, right? It's composed of collagen, glycoproteins, elastin. It's firm in consistency, and then it's decreasing number of smooth muscle cells. Oh, I wasn't going to actually call that a decreased number. Sorry. Okay, decreased number of smooth muscle cells. So we're remembering it's part of the uterus, but it's just the lower part of the uterus. Very little muscle, mostly collagen. So how are we going to open up our cervix for labor? It's primarily about the collagen becoming more and more degraded and moving. So if we see here, this is where our cervix is starting before we get soft. If you think of this as like 5, 4, 3, 2, 1, by the time we're fully dilated, it's like 1 might be way over here because it's all rearranging. So it's moving. It's like it's silly putty. I think of it like silly putty. It's like it's all sliding and moving and pulling upwards. So there's changes in the cross-linking that help the collagen to rearrange itself. So hyaluronic acid participates in that as well, in helping that collagen move. Inflammation definitely plays a role in that, which is where prostaglandins primarily come in. And then, yeah, okay. And then just to keep in mind, oxytocin doesn't help with that collagen realignment at all. So if you have a woman who has a really thick cervix and it's not very soft, and you just start Pitocin, which is the synthetic form of oxytocin, right? It's not going to help her cervix open because that rearranging needs to happen. Prostaglandins need to help with that rearranging. Hyaluronic acid needs to help with that rearranging, and so it would just be like pounding on a hole that's not going to open. So that's why we need to ripen the cervix before we would start an induction, for example. You need to know that the cervix is soft and pliable and ready to be responsive if more and more pressure is applied. But if a lot of pressure is applied and it doesn't already have that baseline of prostaglandins keeping it soft and ready to open, then nothing's going to happen. Well, not nothing, but you get the idea. Okay, so then this is just touching again on the uterus versus the lower uterine segment, which I know we've already talked about the uterus in this class, but just as a refresher. So this here is our cervix, and then there's a thin strip here that's our isthmus, right, the lower part, or the lower uterine segment, and then it's the body of the uterus. And you can see this cervix is really thick here, and then it starts thinning out here and getting shorter. And then here we see it's even thinner and starting to open, and then super, super thin and really open by the time we get to the end. So the isthmus is the lower 1/3 segment, and it does a ton of stretching in pregnancy, but it's not very active in labor. That's that section that doesn't have as much muscle involved, and that's where we want to use a cut. If we do have to do a C-section, we want to cut through that because there's not as much muscle involvement there. So it's growing up and stretching. It's less smooth muscle, and it runs in a different pattern. It's thinner. And then you're able, with a transverse C-section, you would be cutting with the grain as opposed to cutting against the grain. If you were to go vertically, then that would lead to about a 25% chance of a rupture risk, which is why women who have had a classical C-section wouldn't be good candidates for labor. So you want that transverse cut. Just a brief reminder there. Okay, so the uterus, we know it's composed of smooth muscle, and then there's also collagen and glycoproteins amidst that as well. And our muscles going in all different directions, and in different kinds of spiral bundles is how we're picturing all the muscles. So estrogen especially is what's helping with growth and distension of the uterus. So that's that hypertrophy and hyperplasia. Hyperplasia being the cell division there. So how does the uterus contract? This is kind of getting back into Physiology 101. So actin and myosin and intracellular calcium play a huge role, and I have them in the next slide, so we'll get there in just a second. But just to realize we need calcium on board in order to make this happen. Okay, let's see here. Cell surface receptors to hormones, so we already talked about that with oxytocin. And then gap junctions we've also touched on. So then let's just keep going here. So actin and myosin, you can see how it's like they grab each other here and then they pull each other. So if you start here, this is our myosin. It's like this rope piece in the middle. And then it's grabbing onto the actin and then hauling it along, hauling it along, hauling it along. So you go from having a long muscle fiber to a short muscle fiber based on all those attachments. And that requires energy, so we're using ATP. Then you also see that the activator for all of this is intracellular calcium. So we need calcium to make this happen. And it involves burning calories. Okay, gap junctions are helping our unified contraction happen, right? So as the electrical impulse gets sent across all the muscle cell membranes, telling them to contract, it's able to go from cell to cell to cell to cell via this little passageway here that goes from one cell here to one cell over here. So that's our little gap junction tunnel. So that's why we're able to do this synchronously. So we have this rapid influx of calcium that then is moving from cell to cell to cell to tell all the actin and myosin to do their thing. Okay, we'll keep going here. So oxytocin, it's made in the posterior pituitary gland, or I should say that's where it's released. It comes out in pulses, increases intracellular calcium levels once they're bound to a receptor on the cell membrane. So number of receptors increases with gestational age and uterine stretch. So a little bit of a review there. But both oxytocin as well as pitocin increase intracellular calcium. So that's what they're doing. They're providing the calcium that's needed for actin-myosin binding. So pharmacologic agents, we've been touching on these along the way too, but promoting labor, we talk about pitocin, which is our synthetic form of oxytocin. And then to inhibit labor, we can decrease intracellular free calcium. So mag sulfate does that, beta mimetics do that, calcium channel blockers all do that. So those could be used, say, in preterm labor prevention. So without calcium, actin and myosin can't do their thing, and then we can't have a contraction. And then they also block prostaglandin synthesis, which we know also makes the uterus more irritable, and thinking about cervical ripening as well. Okay. So warm-up contractions versus labor contractions. Basically, I just want to show here that generally speaking, so we know that actin and myosin cause a muscle cell to shorten, right? So we have a relaxed cell, and then it contracts, and then it would relax back to this if it was just a warm-up contraction. So occasional contractions that happen throughout pregnancy, it's like we relax, and we're normally relaxed, and then we tighten up, and then we relax again. But in labor, there's this slow progression where it doesn't fully go back to where it was. So it relaxes, but it's not as long as it was, and then it tightens way up like this, and then when it relaxes, it's not as long as it was. So it's getting shorter and shorter and shorter progressively, which is ultimately what we're going to need to bring a baby. So that's, from a physiologic standpoint, that's a difference between Braxton Hicks and contractions that lead to labor. So we'll move right along here. Then our unified contraction, so we build, peaks, and then it comes down. And that's due to our gap junctions helping us to do that all together, like a pacemaker. And actually, I'll just say one more thing about that. So contractions, generally speaking, it's usually either the top of the fundus or more towards one of the two top corners is where it starts, and then it sweeps down from there. So if you think of the top of the uterus or a corner of the uterus as being like the pacemaker, kind of like with the heart with the SA node, and then it wraps around from there. So oftentimes women will say, sometimes you'll hear them say it starts in the back and moves forward, but most commonly it's the top of their uterus is where that contraction is originating, and then it's wrapping down. Cervical effacement and dilation. I like this picture better than what I was showing you earlier for talking about the collagen realignment. So you can see how, like a little piece that might start on the external os here, it's like it's pulling up and back as there's a rearrangement there. So sometimes it's even that pulling up and back, that shearing force, that can even cause a rupture of membranes. And you can see that as this is happening and starting to open, the mucus plug that's been helping serve as a barrier inside the cervical crypts here, you could see how that could come out a little bit. And some women report their mucus plug is coming out in one big glop. Other ones will kind of have lots of stringiness for a day or two or three. Sometimes it's blood tinge, so that's what we refer to as bloody show. And I always sound excited when I hear about that, because it means our cervix is starting to open up. So there's these tiny little blood vessels that are breaking as our cervix is opening, and then that's why we're seeing the bloody show. So that's a sign that labor is coming, or if they're in early labor, it's just a sign that's letting us know that change is happening, which usually people like to hear. Maybe put a little differently depending on who you're talking to. Great. And then just to be aware that multips versus primips, they tend to efface and dilate just a little bit differently, in that primips will generally efface all the way and then they'll dilate, versus multips tend to kind of efface and dilate simultaneously. So membranes, our water breaks early in about 5 to 10% of pregnancies, the bulk of them being term. It's a smaller percentage that aren't term yet. And then almost always labor is going to follow within 24 hours from there if we don't do anything. And then the earlier in pregnancy they are, then the longer it might take to really kick into good active labor. It's associated with collagen degradation, which is happening in our membranes as well as in our cervix. And then it stimulates production of stimulates production of prostaglandins in the membrane. So when your water breaks, that also helps to promote more cervical ripening and get more contractions going, which is why with multips at least it can be an induction method in and of itself. Or if you've heard about sweeping of membranes, which I won't really get into here, but that would also be a part of that same physiologic process there. I'm just going to change this because we see it. Okay. Maternal adaptation to labor. So I'm just going to run through some of the bigger body systems here real quick and just talk about, we know there's differences in pregnancy. How does that translate to labor? So cardiovascular changes. There's a rise in cardiac output in labor, and that can be affected based on what position mom's in, if she's on analgesics as well. So generally there's going to be a slight increase in blood pressure as well as heart rate. That's basically just due to the increase in tone from contractions. Oxygen consumption gradually increases with contractions, so you think about just the energy it takes to be working your muscles, you need more oxygen to do this. So they really are prepping for a marathon of sorts. So we're going to use up more oxygen. May have an increase in number and variety of arrhythmias, so if there's already something different with a baseline there, that can be exacerbated in labor. And then we turn back to pre-labor status soon after delivery. Okay, so then let's think about we're going to do hematologic first. Okay, so our hemoglobin rises during labor and it becomes more hemoconcentrated. And then that can be due to stress, dehydration, and muscular activity as well. Not a very strong rise, but a little bit. And then white blood cells may naturally increase, and then hypercoagulability is increased further, so we need to be ready to make a clot so that we don't hemorrhage after the birth. So erythropoietin is kicking in just before labor and then after labor as well. So we have thromboplastin from the placenta and the decidua, and then a decrease in fibrinolytic activity. So all of those help us make clots easier. And then the erythropoiesis helps to increase our hemoglobin. So respiratory system, so contractions can lead to myometrial ischemia, which can then in turn lead to acidosis. Sorry about all the typos, guys. Oops. There we go. Okay, increase in acidosis because so if they don't have oxygen, then they're going to start finding other ways to burn down fat or muscle, and then we start having anaerobic metabolism. And that can also lead to an increase in pain due to the ischemia. So thinking about pain perception in labor. There's also an increase in rate with a tendency towards hyperventilation. So increased respiratory rate, they're breathing off more of their CO2, so then that makes them have basically respiratory alkalosis, right, which is normal in pregnancy, but that can potentially be exacerbated. Then you can see that with the second stage, you might see women be hyperventilating there as well, partially due to them holding their breath while they're doing contractions and then needing to catch their breath, so you might see that kind of activity there as well. And then we can see that ultimately we're going to compensate for that respiratory alkalosis just like we do in pregnancy, but we don't have as much of a buffer because of the acidosis that's happening from the anaerobic metabolism due to the ischemia of the myometrium. So patients are at a little bit more at risk for acidosis in labor because of that, if they're not quite getting enough oxygen to their uterus. Okay, so renal changes. There's an increase in renin as well as angiotensin, which is important for maintaining uteroplacental blood flow. So we're not wanting to pee out as much, we're wanting to hold on to our water. And oxytocin is actually an antidiuretic as well. So we're holding on to water, which is helping make sure we've got a robust blood supply for giving both the uterus the oxygen it needs to work hard in labor, as well as getting oxygen to the baby in labor. And then after the birth, that's protective for having a little bit of extra blood on board in case we do hemorrhage a little bit. So we're not peeing out very much, we're holding on to our water, and we're thanking our kidneys for that. And oxytocin is playing a role in that. So that's normal and that's protective. If women have an excessive amount of Pitocin or synthetic oxytocin, then there could be potentially a concern about water intoxication. But with normal oxytocin released in the body, that's really not a concern. And then also thinking about the process of birth can lead to bladder as well as urethral trauma in terms of changes. I guess that wouldn't be a normal change, but not really a common change either, but it can happen. And then GI changes, gastric motility is decreased. You think about being in a little bit of a fight or flight state. Now is not the time to need to go to the bathroom all the time. So gastric motility decreases, delayed emptying. This is assuming we've already kind of had our pre-labor loose stools or whatnot. And then there's also a rise in the acidity of GI contents. Okay. So last one here, metabolism. We burn a lot of calories in labor. So 700 to 1100 calories per hour. That's really, really, really crazy. Advocating for our low-risk moms to be able to eat as they're feeling the need in labor is so important that way. And I just think about as soon as women have delivered, that's one of the first things I like to send their way once things have calmed down is asking them what they're hungry for and getting some more food and meat on their bones. Because that's a pretty hardcore workout. So maternal glucose consumption increases, obviously, because the uterus is working so hard in labor. And then you notice women postpartum end up sore in all sorts of places they had no idea they could be sore. And I'll say the same for dad, too. So feeding him is also important. And everyone's going to be sore and everyone's using muscles that they're not necessarily used to using. Lipolysis produces ketones. And we talked about that in the last slide too, or maybe a couple slides ago when we were talking about uterine ischemia. So breaking down fat, that's causing the ketones to be made, and then that can interfere with fetal pH as well as the uterine activity. Anaerobic metabolism is producing our ketones. Oops. I'll do that. Okay, and then increase in temperature may indicate dehydration or infection. So just to be aware of that as well as far as normal metabolic changes in labor are concerned. Okay, and again we have less of a buffer in the blood with all the ketones on board to accommodate for that respiratory alkalosis. So we do have a little bit more of a risk for acidosis. Metabolic acidosis due to the ketones. And encouraging moms, when they are drinking, to drink something with some glucose in it. Think about she's got that great water, spiking it with some juice. Even if she'll just have a little bit that's diluted, the more we can keep feeding her uterus, the more we can keep her strong, so her body can keep doing its work. So let's just talk a little bit about labor pains or surges or rushes or contractions, however you want to talk about them, for how women are perceiving what they're feeling in labor. So let's first just talk about it as pain. So we already mentioned the uterine hypoxia piece due to the ischemia during contractions. That can lead to perception of pain. Cervical stretching and pressure on nerve ganglia within the cervix, that can be painful. Traction on tubes, ovaries, and peritoneum, so everything is moving and shaken. Stretching of uterine ligaments, pressure on the urethra, bladder, and rectum, just distension of the pelvic floor muscles and peritoneum in general, all of those can contribute to it. And as far as the actual contraction goes, that hypoxia, you can kind of think of like a Charlie horse at its height. That is a good visual for you. So character of labor pain in the first stage, generally it's perceived lower in the abdomen, maybe suprapubic, and it radiates down thighs to the sacral area. They get some relaxation in between contractions, and pain is almost continuous by the end of the first stage. So thinking of first stage as latent labor up until pushing. So actually I would say it starts maybe more mid-abdomen earlier in the first stage, but then I think of the bulk of first stage as being active labor. So when we're actually with women, so lower in the abdomen, radiating down the thighs. Increased catecholamines are responsible for that discomfort, and then women will have an increase in cardiac output, heart rate, blood pressure, respiratory rate, pH, and then a decrease in cerebral and uterine blood flow, stomach and bladder emptying. Okay, because we're thinking about that acidosis piece here with the ketones. Okay, character of labor pain in the second stage or pushing. So perineal and rectal pressure are a big part of that. That burning, stretching, tearing as the head is descending the vulva, also known as the ring of fire. Leg and thigh cramps, little abdominal or back pain anymore as baby ends up so low. Oftentimes we're past that being the bigger issue once baby's head gets that low. And then there can even be a deep relaxation between contractions. So that transition period towards the end of the first stage can be so intense in contractions, one on top of the other. And then sometimes moving into the second stage, it's like women actually kind of get a break. Most women prefer to be pushing, and they feel like they have more of a job other than just relaxing, and they can really do something with it. And then oftentimes, ladies, their bodies will give them a break, so they'll maybe even doze off a little bit in between contractions for the pushing phase, depending on how that's going. So sources of labor pain can be visceral or somatic. So visceral, thinking about originating from organs of the body cavities. So it's more of like a burning, gnawing, aching kind of a pain. So contractions, cervical dilation, stretching of the vagina and the pelvic floor. The body of the uterus is served by autonomic nerves. So that's T11, T12, and L1. That's making up the bulk of the uterus there. That's what we're targeting with epidurals. And then the cervix is innervated by the sacral plexus. So that's S2, 3, 4. So those are our nerves that are perceiving this. Okay, so then somatic pain is arising from skin, muscle, joints. It's more superficial. It's more, you might hear words like sharp, prickling pain, deep burning pain, or aching. Tends to be diffuse and longer lasting. So I think about the distension within the birth canal as well, vulva and perineum. You can see there's some overlap between the two. But sensations from the pelvic floor travel from the pudendal nerve to the sacral plexus. So that's where we could do a pudendal block if we wanted to help. If what was making her particularly uncomfortable and what she was wanting relief from had to do with baby's head distension within her vagina, that would be an option for targeting that nerve specifically. And then superficial, we've got the delta fibers, and then deep somatic, we've got the small and myelinated C fibers. All right, and then when I think about the last two, I think about those are what's influencing potentially how we can control some of the discomfort via like the gate control theory, talking about like if you're distracting certain nerves such that it's kind of like they get fried and they stop sending messages to the brain. Sterile water is a good example of that. If you put like 4 little pockets of sterile water in her lower back, just under her skin, then it feels like a bee sting, and it's like it distracts those nerves. So it's really, really painful for maybe 45 seconds or so, and then she can have relief for up to an hour and a half, 2 hours, because it's like we've just distracted those nerve fibers, and they're going to just stop sending messages for a while. I would not do that unless someone had really bad back pain. So pain mediators, endogenous pain mediators would be like endorphins that mom's releasing for herself. I think about moms wanting to turn more inward to themselves. I call that labor land. You'll hear that term used sometimes as women really start to get deeper into active labor and kind of almost transition-y. It's like they come into their own little central world, and that's all they know, and they're turning inward. Maybe gearing up for pushing, you might start to see that, and you say they're in labor land, and that's kind of like a protective mechanism for themselves that's helpful for pain mediation. Exogenous, we'd have non-pharmacologic options, like water, feeling safe, creating safe space for her, position changes, counter pressure, massage, guided imagery, breathing techniques, aromatherapy, sterile water, like I mentioned. There's a lot there, and I'll save that so you have something to talk about in intrapartum. And then pharmacologic, thinking about epidurals would be the most classic example there, but there's other options there as well. Okay, so here's our little ta-da moment of we just had a baby. Those are such good shots. All right, so baby's out, and then third stage, we need to be able to clot off our blood vessels, so we have that thrombosis ready to go. And then initially we've got a strong uterine contraction, and then a formation of a scab-like area on the uterus, which is called an eschar. And I think in your postpartum lecture I was all confused about how to pronounce that, but it's eschar, as in it's like it's going to turn into a scar. Eschar. Okay, now we know how to pronounce it. And I use this picture here because I just wanted to have you think about this is the space that the placenta is occupying, so then if the baby comes out, it's like really the placenta is even bigger than the space that the uterus would occupy, which is why it's going to buckle and fall out now, which is what we'll be doing in this next slide here. So it's forced to shear off because there's no more room once the baby's out. So decompression of the placental site, retraction of oblique muscle fibers. So it starts to buckle in here, and then you might have some blood that's leaking out on the other side. So oftentimes the placenta comes out, and there's a couple clots that kind of come with it. But we've got all these blood vessels in here, and so as this smooth muscle is shrinking down, it's cutting off those blood vessels that are inside there. And then we've got the weight of the placenta as well as the blood here also helps it to continue to shear off. And sometimes it kind of gets caught right around the cervix, but then it's not too hard to get out there. So I think I've got one more slide here. Yep, so signs of placental separation. If you see like a gush of blood, oftentimes that can be like if it's more the corner of the cervix or of the placenta that started to give way. If everything's been kind of going just fine postpartum and then she has kind of a gush of blood, that would be a sign that maybe our placenta's ready. If she's reporting pretty strong contractions or a strong urge to push again, then that would be another reason to have a little light go off in your head. Oh, I wonder if our placenta's ready. And then oftentimes with that, you'll see the uterus kind of rise up and be firm and kind of globular, like it's contracting really strong to get the placenta out. And then if you've put a clamp on the cord and you see that that cord is lengthening, or if you're pulling on the cord and it's easily lengthening, then that's another sign that it's ready. So if it hasn't separated from the uterine wall, no amount of tugging is going to force it to come off, and you would be at risk for pulling her whole uterus out too. So basically what we do is we put one hand up here above the pubic bone, and it's like it supports our uterus, and then we pull with this other hand. And if it's started to shear off, then it'll come for you nicely, and if it's not coming, then we just let it be and we wait. So that's our placenta. And then facilitating maternal-infant attachment. I just wanted to end with this. So oxytocin is linked with bonding. Oxytocin is released in 3 different types of time periods. So one would be orgasm, which is also very associated with bonding. And then another one obviously is labor. And so you've got all that bonding hormone rising to a peak right at the birth. And then the other time is with breastfeeding. So that's the milk ejection reflex is with oxytocin. So that's another time to be promoting bonding. So early interaction between mother and baby is important for helping to facilitate maternal and infant attachment as well. Delaying any procedures that are important right away. So, we don't need to know exactly what baby's head circumference is 2 seconds after they're born, right? So delaying anything that's not important. Early breastfeeding. Not separating mom and baby unless it's medically necessary. And then just addressing maternal discomfort, whether that's ibuprofen or helping get her bottom cleaned up nicely, whatever that looks like, so that she's comfortable and can just focus on resting and being with her baby. giving the family unit respect and space, and then spiritual support. And I think of this as like allowing openness and freedom for women as well as their partners and their family unit to just be able to fully express themselves physically and emotionally. And I think of this for labor too, for spiritual support in labor, and then in the postpartum period as well with bonding, to just give them permission to be and feel exactly as they want to be and feel, and to just in that moment give them complete acceptance. We talk a lot about birth territory in midwifery, and I think postpartum, that initial postpartum period, that is so fresh. We have an expression where we say that we like to hold the space. So how can we hold the space for women? So the baby is born, you catch the baby's right up to mom's chest, and then really nothing needs to happen right then. You can watch her bleeding, you can be seeing that baby's pinking up, we can help dry off the baby, and then just letting that family unit be and just kind of hold and guard and protect that space for them to just be able to fully bond with their baby. And we can do all our little assessments from just a little bit of a distance. Can give them a sweet introduction to their new baby. Great. And then I just wanted to expand just a little bit on spiritual support, not just postpartum, but thinking about labor too. There's four main areas that I think of for spiritual care, whether they're in labor or not. So I'll tell you what they are, and then we can think about which ones would apply to labor. So love and relatedness, meaning and purpose, forgiveness, and hope. So those are all spiritual needs that we all have, regardless of maybe what religious background, if any, we're coming from. All of us have the spiritual need to feel love and connectedness with others. We all have the need to have some kind of a meaning or purpose. And then forgiveness, thinking of that as a spiritual need, whether that's with God, whether that's with relationships we have with other people. And then hope is a spiritual need as well. And I think maybe all of those except for forgiveness are really strongly seen in labor. So that need for love and relatedness, having a partner there that's really supportive, that connection between the baby and the mother, and that baby needing love and relatedness even as soon as they're born. That's so much transition for a baby, to be in an environment that is supportive and loving, and enveloping from the moment they're born. Moms have so much purpose and so much meaning in labor, and hope is a big one. And sometimes we lose hope in the middle of labor. Sometimes we think the baby is never going to come. I'm speaking of the royal we with mothers. So how can we be instilling hope for the birth that they're wanting? How can we be continuing to be encouraging? What does it mean to be providing spiritual care for women while they're in labor? I think presence is a huge piece of that. Much more on presence to come as you go through midwifery school. Our last president, Ginger Breedlove's our current president for ACNM. Our last one was Holly Powell Kennedy, and she wrote just this awesome essay that you should look up, that's all about midwifery presence. She calls it The Art of Doing Nothing Well, which is a huge part of what we're about, and I feel like she's one of my heroes. And I'm always afraid I'm telling you guys soapboxes that I may have already given you, but she would be worth hunting down if you haven't read that essay. Love Holly Powell Kennedy. So she's over hanging out at Yale. We love our fellow schools. Okay, so here's my final grand hurrah with birth pictures. So much emotion. I just love these shots. So, what do we have in common as midwives? We're all promoting normalcy. We're all wanting to respect and honor and give space for this normal process to develop. we're all going to have different styles for what that looks like, and I think that that's beautiful. I'm one of those people who, maybe not always, but generally tends to think that women end up with the midwife that they need when they're in labor, even if it's maybe not the midwife they were hoping would be on call when they go into labor. They end up with the midwife that they're going to need. Or at least I tell myself that when I have to leave a birth that I wanted to be at. But really, we're all very different, and nobody's going to be a midwife just like I'm a midwife, and nobody's going to be just like their preceptor, and we're all bringing something different to the table, and that is beautiful. And women are even more different than we as midwives are different, and that's a really big strength. The more diverse we can be as midwives, then the better equipped we are to be able to care for diverse women. And I love that we're all going to have slightly different styles and slightly different ways that we're promoting this normalcy in our own practice and empowering women in our own practice. And I think many of you are really grasping on to our core competencies and what that looks like, which I just think is wonderful. So I just want to end with one of my favorite quotes, and it's that we have a secret in our culture, and it's not that birth is painful, it's that women are strong. So let us empower them in pregnancy to do this beautiful work of birthing. Hope you all have a wonderful week.